Children's Grand Rounds. It's my pleasure this morning to introduce Dr. Nick Staab. He's one of our former and still present PCH employees in the hospitalist division, but his main job now is working as a medical epidemiologist, and he's the deputy medical director for the Maricopa County Department of Public Health. Previously, he was the medical director for the Bureau of Epidemiology and Disease Control at the Arizona Department of Health Services. He also works clinically here as a hospitalist when he can. He's a Master of Science degree in Public Health and Microbiology and Emerging Infectious Diseases from the George Washington University. And his doctorate degree came from the Keck School of Medicine at the University of Southern California. Dr. Staab is a native physician and Phoenician and lives in Central Phoenix with his young family. So Dr. Staab, welcome very much. And we all look very much forward to learning about a disease that we probably never diagnosed a case of.
Thank you, Dr. Hartley, for that introduction, and thank you all for coming. Dr. Hartley says that this is the largest in-person crowd maybe that we've had at Grand Rounds for a while, so that's exciting for me and also exciting to see a lot of familiar faces. It's usually a pretty easy crowd to talk to for me. So again, I'm Dr. Nick Staab, medical epidemiologist with Maricopa County Public Health. Here today to talk to you and present on a couple of cases of locally acquired dengue infection that we recently discovered and investigated here in Maricopa County. Hopefully through the course of this presentation, you might be almost as excited as we were when we discovered these cases and did the investigation. The implications of these two cases and the positive mosquito pool that we discovered are very interesting for our community and for our region. And so I'm kind of going out on the on a little circuit here of Grand Rounds around Maricopa County, trying to inform as many healthcare providers as I can about this, so that going into our next mosquito season, we are well informed and thinking about dengue virus. So I will this morning go through what historically has been our epidemiology of dengue here in Maricopa County. Talk to you a little bit about or most of the time talk to you about the investigation of these two cases and what we've been doing in public health to learn more about the transmission of dengue here in Maricopa County. And then talk to you about messaging. What's our messaging out to providers in terms of thinking about dengue virus, including it in your differential diagnoses, appropriately testing for it, and then what is our prevention message, which with mosquito-borne diseases is really kind of the critical piece that we want all of you to understand and talk about with patients. All right, so dengue, whether you're familiar with it or not, is a mosquito-borne illness. So we're looking at the Aedes aegypti mosquito, which I'll talk to you a little bit more, is a different species of mosquito than what we're used to talking about here in Maricopa County, primarily when we're thinking about West Nile virus. But transmission is through the bite of that mosquito and through the bite of an infected mosquito. The incubation period is up to 14 days, but usually around a week. So 14 days will be important when we're kind of talking about how we did our investigation and how we consider a locally acquired infection versus the more common here, which is a travel-associated infection. With dengue infections, only about 1 in 4 infections are symptomatic. So most are asymptomatic. So again, something we need to be thinking about when we're considering infection in a person. And symptoms can vary in severity. So like a lot of illnesses, from mild to severe disease. There are 4 serotypes of dengue virus, 1, 2, 3, and 4. All of those serotypes can cause severe disease. And as I'll review here shortly, it's really a subsequent infection of dengue from a different serotype that often leads to more severe illness. So in many parts of the world, dengue virus is not much of a thing to talk about. It's endemic. A lot of people have either been infected or know people who've been infected. So mostly tropical and subtropical regions here. I'll blow this map up on the next slide, but estimated 400 million infections, 100 million cases per year around the world. And again, frequent dengue transmission in Mexico and the Caribbean, which is notable for us here in Maricopa County. So I think the most important thing on this slide is to note that Sonora, Mexico, I'm trying to have a cursor. No. So Sonora, Mexico is dark blue. So continuous and frequent transmission just over our southern border. We have a lot of our population that frequently goes back and forth to endemic areas. So seeing travel-related cases of dengue virus here in Maricopa County is not unusual, and we regularly do see those. So dengue virus here in Maricopa County, really looking at what is endemic here versus what is travel associated or what we would call imported diseases. So what we are used to seeing here in Maricopa County in terms of mosquito transmitted diseases are West Nile virus and St. Louis encephalitis. They tend to kind of go back and forth every other year. You'll see more SLE or West Nile virus. Notably in 2021, our West Nile virus season was the highest on record anywhere. So I think in 2021, Arizona was hitting a lot of records, a lot of COVID, but we also had an incredible amount of West Nile virus. And so we spend a lot of time in public health paying attention to West Nile virus. Notably, West Nile virus is transmitted by the Culex mosquito. So this is a different species again than what we see with the flaviviruses such as dengue, Zika, and chikungunya. So a lot of our mosquito surveillance, what environmental services for county does, is based on Culex mosquitoes. So all of our trapping and our routine surveillance is based on Culex and testing them for West Nile and St. Louis encephalitis. So routinely, we're not checking our mosquito population here for dengue, so we wouldn't necessarily know it's in the mosquito population unless we go looking for it. The difference in those mosquitoes is also notable. Aedes doesn't go very far, so I kind of think of it as a lazy mosquito. They're not very good flyers, so they stay relatively close to where they're born, whereas Culex can go much farther, so that definitely has implications in terms of what we're thinking in terms of investigations. So if you have a positive mosquito pool, as I will show you in a bit, with Aedes, you're looking at a much smaller area by which you might see transmission from an infected mosquito population, whereas Culex can fly up to 5 miles. Again, a lot of our routine investigation in public health is focused on West Nile virus and St. Louis encephalitis. So I mentioned that we routinely see dengue here in Maricopa County in travel-associated cases. So almost whenever one of these cases gets reported to us from a lab or a healthcare provider, we will do our routine investigation. That includes asking in that incubation period up to 14 days prior to the onset of symptoms, did you have travel? And inevitably, in every case that we have investigated in Maricopa County to date, you find good travel history to an endemic area. So on average, that's been about 7 cases per year of dengue fever. So again, that that investigation includes a case interview by our public health nurses, review of medical records, and oftentimes doing additional testing on those specimens. So frequently we'll have serologies come back positive for dengue, as I will, or oftentimes those can cross-react with other flaviviruses, including West Nile virus. So almost always we will take those specimens and do additional testing to confirm that it is dengue, also to know what serotype it is for records. So this case, go through kind of a timeline of events to explain what public health does in terms of responding to these cases. So on November 7th, our initial patient A, was reported to be positive for dengue virus serogroup 3. And that was confirmed at the Arizona State Public Health Lab. So again, forwarding that specimen from whatever lab performed the serology. Here, our state lab can confirm serotyping for dengue virus. So just like I explained, you start that investigation with case A, looking at when the onset of symptoms were and in that time prior to it. And interestingly, this patient did report having travel in that time period over the border to Mexicali. It was about a 4-hour visit over the border. The patient did not describe any known mosquito encounter, they didn't describe being bitten by mosquitoes or seeing mosquitoes. They had this short trip over the border and came back home. So in our investigation, was there travel associated to an endemic area for this case? Yes. So you could kind of leave it at that, but it was such a short period of time that it triggered public health to take some additional steps, which was going to environmental services and asking them to do surveillance of mosquitoes in that same time period near that individual's home. So environmental services saves every mosquito pool that they collect for a long time. There are these little mosquito boxes that are frozen, and so they can pull those out and do additional testing. So like I said, this was not, we don't routinely test for dengue in our mosquito pools. And so they're able to retrieve, I believe they did the 5 pools within a 5-mile radius of this individual's home. And lo and behold, one of those pools tested positive for dengue virus serogroup 3 near the individual's home. So this is when we started to get real excited because, again, we have never found dengue virus in the mosquito population here in Maricopa County, much less within a reasonable distance from a case who didn't really have a good travel-related history. So again, we had a dengue infection with a possible exposure to a positive mosquito pool here in Maricopa County. So obviously that is not usual for us. And again, the routine mosquito testing did not reveal the dengue virus in the mosquito pool. It was us asking for that testing related to the case. And again, this had never been discovered here in Maricopa County prior. So the other cool thing you can do is not just knowing which serotype it is, but send it on for genetic sequencing. So the CDC lab in Puerto Rico is kind of the main lab for dengue virus analysis. So we sent the mosquito pool as well as the sample from the individual down to Puerto Rico, and they found that the 2 samples were very closely linked genetically. Interestingly, also, the serogroups that are being transmitted in Sonora are serogroups 2 and 4. Dengue virus serogroup 3 has not been detected in Sonora, so another additional evidence that this was not related to that travel over the border. And again, apparently most of what we're seeing here in the continental US in terms of cases are serogroup 3, seem to be related to the dengue virus serogroups that are being transmitted in Cuba, which is seeing a large number of cases recently. And so likely travelers to Cuba in areas nearby who are acquiring dengue virus 3 and then bringing it back to the areas they're from here in the US. So our next steps, so we have a plan related to outbreaks of mosquito-borne illnesses here in Maricopa County. Again, that plan is shared between public health and environmental services. And so on November 10th, we activated our incident command to initiate enhanced surveillance of dengue in the county. So what is enhanced surveillance? So again, as I mentioned, routinely when these cases come in, We do that investigation, we find their travel history. That's kind of case closed. No additional investigation is done. But because of these cases that appeared to be locally acquired, we did go back and look at all previously reported cases, including negative cases. So again, as I mentioned, sometimes those serologies may be reported negative. Sometimes they may cross-react with other infections. So pulled all those cases to review if there had been anything else interesting about them. And again, in 13 suspected cases that were pulled, there's no evidence of local transmission. And then we initiated prospective enhanced surveillance. So looking forward, they were going to investigate every case that was reported for evidence of local transmission, as well as expand our investigations team to accommodate any potential influx. Because again, anytime we go out, like I'm doing right now, and describing these cases, we expect that additional testing will be done, which is a good thing. But we also need to have our staff prepared to do those investigations as those results start coming in. So again, public health's role in many cases is just to get the word out, to make sure the providers are aware of what's going on, and then also to do public communication, which will largely revolve around our discussion of mosquito prevention. So when we put this out, this was what, early November. So you all may remember there was kind of a big election period. And so dengue virus largely got buried under election news. But it was out in the paper, and we did additional messaging through what we call a serve alert, which is messaging out to providers to let them know what's going on. The number one question that reporters wanted to know is where did this case live and where was the positive mosquito pool? We consider that protected health information, and so we did not share that. And so people were really angry that we were making this announcement but not telling them where it was. Interestingly, Aedes aegypti mosquitoes. So again, we don't try to trap them. We try to trap Culex, but we get lots of Aedes in our mosquito traps. And Environmental Services has reported that they're all over the county. They're not just in one area. The potential for transmission of dengue is throughout the county, and that was really our message there. So additionally, we did retrospective dengue testing. So considering when the onset of our case's illness was in the 14 days prior, we wanted to see if there was evidence of dengue and other mosquito pools around the county. Again, that initial survey of mosquitoes was only in the 5-mile radius around the individual's home. So we're very thankful to Environmental Services, who tested an additional 4,300 pools around the county. So they just pulled every pool that had Aedes mosquitoes in it in that incubation period and tested back, again, considering the incubation period. So that was September 18th through November 19th. And the only positive pool in that period of time was the pool closest to the case's house. And then additionally, we asked to prospective or ongoing look at any pools that trapped Aedes mosquitoes for dengue virus. Again, that was not the usual routine surveillance that Environmental Services has done. And to date, we've had no more positive pools. So the next activity the public health wanted to do was a sero survey of this area. Again, considering that only 1 in 4 individuals who are infected with dengue have any symptoms, the thought is, well, this positive pool and this positive case in this area, there certainly could be others who were infected and just didn't know it. Maybe they had mild illness and didn't present to care, or even if they did present to care, again, without having the travel history, many providers wouldn't think that what their illness was dengue. So we went out into the community again, drawing circles around both the positive pool as well as the case's house. We identified households in the area to approach and ask for participation in a serosurvey. Environmental Services also was out with us in the field and offered to do environmental surveys at each of these homes, looking for mosquito breeding sites and offering additional education. So we developed a survey to give in the field, asking people just about exposure to mosquitoes and any possible travel that they may have had. And then we also performed phlebotomy and did dengue testing at the state public health lab. And again, Environmental Services was with us as well. So that survey took place November 17th and 18th, with one cleanup day on the 19th. We had 5 field teams, so we're very thankful. We have a large number of medical volunteers who accompanied us. CDC came out and to do an epi-aid, so we had a couple of experts here. We approached 240 houses in this defined area. And 53 people agreed to participate in the serosurvey. So of those 53, 12 reported any ill symptoms in the 14 days prior to the survey. So again, that will dictate what kind of testing we do. So if you have any ill symptoms, we'll talk a little bit more about what appropriate testing is. Then we would perform PCRs on those individuals. Everyone else who was not sick in the 2 weeks prior would just get serologies. And so there were 41 asymptomatic in the 14 days prior and 12 who reported any symptoms. And again, we get very excited about little things, but there was one additional person who was asymptomatic in the prior 14 days, but who tested positive for dengue by serology. And when we confirmed that by neutralization plaque testing, it was dengue 3. So it was, they had no travel, and they did report ill symptoms back in I think they were back in August. I'll have the timeline coming up here, but so much earlier in the summer than case A. So case B was actually sick before case A, but again, had positive serology for dengue 3 and matched genetically as well. So this is like exactly why you do this, is to find these extra cases and show additional evidence of local transmission. This was our serosurvey testing flow. Again, most of the initial testing can be done here locally at the state public health lab. But as I mentioned, because of the cross-reactivity with other flaviviruses, we send any positive results onto the lab in Fort Collins, Colorado, and they're able to do the plaque neutralizations there to confirm dengue. So again, interesting here to think about the symptom onset dates for these 2 cases. Again, case A had symptom onset in mid-October. Case B had symptom onset in early August. So when you think about including the incubation period, this is evidence to us that there was local transmission of dengue from July to October. So just in consideration of that length of time and the number of people, in the fact that we found 2 cases in this small community, the possibility for more cases locally is pretty astonishing. So another thing that we've asked of healthcare providers is to think back. If you've had any cases that were undiagnosed of febrile illness within that period of time, it is possible that it could be dengue, and individuals could still test positive by serology. So by January 4th, which was 45 days after the locally acquired cases were positive, we declared that outbreak over, and that was the end of our response to dengue this season. So a couple of things just to note about public health responses. This was a very well coordinated response. Both public health and environmental services had to work very closely together to do both the human and mosquito surveillance. We established great partnerships and plans, worked closely with the state health department as well as CDC, and then have continued to work closely as we develop a plan for both mosquito and human disease surveillance in the season ahead of us. So again, dengue messaging, we really want to get the word out to the healthcare providers in the community about this so that they're thinking about dengue. So again, we use this enhanced surveillance alert. One of my hopes is now that we are out of emergency response for a number of things, that I have some time to modernize our outreach to providers. Our serve alert goes out by email. I imagine many of you don't receive those emails because it's a little antiquated how we get on these listservs. But these certainly go out to infection preventionists, ID docs in the community. So they're really they take on a lot of the additional work of getting this information out to all of you. This was, what date was this? This was an update on January 13th. And that was when we announced the second locally acquired case. So we want to communicate about symptoms. These symptoms, as you will agree, are very non-specific. Again, 1 in 4 cases are either asymptomatic or have mild disease. But of those who are symptomatic, they will have fever and rash, notably. Any kind of headache is often described as retroorbital eye pain. And then very characteristically of dengue fever is muscle and joint pain. Severe disease is often some kind of bleeding or hemorrhagic disease, including nose bleeding and bloodshot eyes. And then obviously severe dengue, which can include abdominal pain, vomiting, and more bleeding. So we talked a little bit about dengue testing. I think there's some things that are a little interesting about dengue that are a little different from other infectious diseases that we may be testing for. Again, for acute illness, it's really important to do the PCR. In the first week of illness, you probably won't have positive serologies, and so you won't catch it unless you order that PCR. In the middle of around 7 to 14 days of acute illness, in public health, we recommend that you get both the PCR as well as the serology. And then after 7 to 14 days, it's really not as important to get that PCR, more important to get IgM. And IgM antibodies in dengue last longer, I think, than what a lot of us think of in getting IgM and how long you can detect IgM. So in dengue virus, you can detect it for up to 6 months after that illness. So again, if you have anyone and you're considering dengue virus in an illness in the last 6 months, we would recommend getting a serology and getting that IgM. Most important that you're ordering IgM, but I know that a lot of testing would get both IgG and IgM. And as I mentioned, there's a lot of cross-reactivity with these serologies with other flaviviruses that are more common here in Maricopa County, including West Nile and St. Louis encephalitis. And so if any of those serologies test positive, again, public health and our investigation of those cases would would help perform additional testing to confirm a dengue infection. There is a dengue vaccine that is authorized by the FDA. It has very unique authorization. It is only approved to be used in children ages 9 to 16 who have a lab confirmed previous dengue virus infection and who live in an endemic area. So because this is not, Maricopa County is not an endemic area officially, the vaccine is not available here. In the US, it's only in Puerto Rico that the vaccine can be used. And in order to use the vaccine, you have to have that lab confirmed prior infection. Not in its clinical trials, but once it was being used more broadly, there is a safety concern for individuals who did not have a previous infection but were vaccinated, and then with subsequent infections of dengue develop severe disease. So thinking that the vaccination actually primed the immune system like an initial infection would, and then they had more severe disease with subsequent infections. There is another vaccine in the pipeline that is slightly different from the vaccine that's currently authorized, and it would not need such strict administration rules. So we're kind of hopeful maybe by the time we're declared to be an endemic area that we have that vaccine. And then just a little bit more, we talked about the mosquitoes earlier, but it is really changing the way we're messaging our mosquito prevention efforts, looking at the way the Aedes mosquitoes behave versus Culex. And so traditionally, with our Culex messaging, we really focused on that dusk and dawn as being the most important time to practice your prevention efforts. Aedes, unfortunately, doesn't have a watch. They're out all the time. And so it's not just at dusk and dawn that people need to be thinking about mosquito prevention, but all throughout the day. Culex conveniently really likes to stay outdoors. They're not interested in being inside, but that's not the same for Aedes. They tend to be found indoors as much as outdoors. So it's really important that people are thinking about doing things like repairing broken screens and keeping doors and windows shut during the mosquito season. Where they breed is also important. So Culex likes to breed in kind of larger water collections. Aedes really prefers very tiny collections of water. So, I mean, just at every one of these steps, they're more annoying than Culex. So they like the size, something like the size of a bottle cap upturned is what Aedes prefers. And so our kind of like tip and pitch messaging in terms of getting rid of standing water is really different for Aedes compared to Culex. Culex really focuses on, you know, making sure that you don't have large pools of water and pet water bowls and that kind of stuff out. With Aedes, we really need to message that it's anything, any small collections of water or possible breeding sites. And then again, the difference between the two species in terms of how far they can fly. Culex obviously can go much farther. So environmental services conveniently creates heat maps for us. So again, we have tons of mosquito traps throughout the county. And so we get maps of where the mosquito densities are higher. So we know kind of which parts of the county we could really focus our mosquito prevention efforts in. With Culex, those heat maps don't necessarily, the heat maps of mosquito density don't as closely match our heat maps of human cases. So I mentioned that 2021 was kind of a big year for West Nile virus. So if we look at our heat maps of cases, there's some overlaps with the heat maps for mosquitoes. But again, because Culex tends to travel farther, it's not as closely aligned. Again, it's hard to make a heat map with two cases. from the 2 cases of dengue we found, but it is rather notable that both of those cases were within that very confined region where we found the positive mosquito. So our ongoing surveillance will continue to look at those heat maps. Additionally, we are adding Aedes specific traps to our surveillance. So we should be able to trap more Aedes mosquitoes moving forward. Interestingly, CDC, when they were talking with our environmental services folks, were pretty astonished at the number of Aedes mosquitoes that we were trapping, seeing as how we were not trying to trap Aedes. They were saying that some of our traps were had much higher densities of Aedes mosquitoes than what they were seeing in Puerto Rico. So it's not great news for us. But the prevention message is the same. So whether it's Culex or Aedes, repel, remove, repair is what we use, kind of the 3 R's, making sure that you're using insect repellent. Again, no longer just at dusk and dawn, but anytime you're outdoors with exposed skin, removing standing water. And again, now focusing on even those very small collections of standing water, and then repairing screens, making sure that you can keep mosquitoes outside and away from you. And again, the biggest change in that from our messaging perspective, and again, we do a lot of public messaging around West Nile virus, is really all hours of the day people need to be thinking about mosquito prevention. Remember, this is mosquito borne, so you have to have that. The mosquito has to get infected to transmit it to more people. And so when you're talking about dengue and when you have a positive dengue case, it's really important that in their, while they're acutely symptomatic, that they are avoiding being bitten by mosquitoes. Because again, that's the way you introduce the virus into the local mosquito population. You know, if the Aedes mosquito is only flying a couple of meters, they're probably not getting it from Sonora, Mexico. It's a human getting it and then infecting the mosquitoes and then perpetuating the transmission. So again, change in the messaging about the time of day for protection, as well as the size of water collection is what we're focused on. That is all I have to see. I think I saw a raised hand, so let me go. John, can people ask questions from the remote audience?
Yes, in fact, we got one here from Dr. Balan. He says, it's under the Q&A. He says, when the locally acquired DMV case was reported, we set a testing mechanism for samples to be sent to Mayo Clinic. Is testing through the county only available for confirmation?
Yes. So we would only know about a case when the testing was initially done and was positive. So, but if you did serology, so I don't know what testing is done at Mayo. I'm guessing it's PCR. But if you send out those serologies and the serologies are positive, in our routine investigation, we would arrange for testing at the state lab.
Okay, 2 more questions. One from dermatologist. Can you please repeat the skin manifestations? And maybe go back to that slide and just, my question was going to be like, if dengue is going to be hospitalized, what are the many things that they'd be coming in for? And then Dr. Balan replied, NAAT, serology, and antigen test.
Okay. Yeah, so I would say, again, based on, so for the question about testing, based on symptomatic or not, if they're not symptomatic, really focus on getting the serology testing. If they're symptomatic and within 7 days of the onset of symptoms, get that PCR or NAT testing. And then between, I think we say usually between 7 and 14 days after symptom onset, getting both is helpful. Again, any of those positive PCRs or serologies would be followed up in the routine public health investigation, and any further testing to confirm would be done at the state lab or through CDC. I have to admit, I am not a clinical dengue expert. So I probably cannot give any more specific details about the rash than Dr. Price could probably find. So I don't want to claim to be any expert. I think really general flu-like illness is what most cases of dengue are presenting as. I believe from my understanding, the rash is very non-specific. So there's nothing about the rash that you're going to see and say, this is dengue. I think you really have to have the knowledge that dengue is a possibility and that it's something to test for. I think especially for individuals who have had a personal history of dengue infection. So to your question, John, about what would we expect in terms of people who'd be admitted and hospitalized, oftentimes those are subsequent infections. So again, somebody who has a known history of dengue infection would obviously be would bring that higher on your differential if they're presenting with severe disease. The other symptom I think that's really notable for dengue infections is the muscle aches and the joint pain. So dengue fever is also known as breakbone fever because individuals will really feel that severe muscle and joint pain. So I think that in conjunction with fever and flu-like illness and the history of mosquito exposure. So I think that's one thing that we probably are not very good about routinely asking in individuals who are presenting with a febrile illness. But if it's mosquito season and someone's having febrile illness, flu-like symptoms, and they report that they have mosquito exposure, then I think that should raise dengue on all of our differentials.
Couple more questions. One, is there any person-to-person transmission? And I'm guessing the answer would be
no.
No, unless they live close to each other and they get bit by one. A mosquito bites one and bites the other.
Correct, which luckily we would still not describe as person-to-person. Yeah. It's still, it requires that mosquito in the middle.
Okay, one of our ER docs says, will there be an order set for mosquito-borne serology testing? It would be helpful for all, but especially in the ED where we often don't have time to figure it out. That might be more of a ID question here.
Yeah, and I think considering how much West Nile virus we have here, as well as this news, I think that would be helpful. Anything that can be done to help remind providers and to think of it.
Okay, I think we have some last questions here too. So
yeah,
and go ahead and repeat those for Zoom.
I was going to say that my family is from Jamaica, and so like dengue is very common there. And like most people presenting have like some friends that are physicians there too. A lot of times they have excruciating pain with the high fever, so that's something that leads them to test because they just can't even get out of bed because of the muscle pain and the bone pain. And then if they have a high fever, then they have.
All right, so for the audience online, the comment was kind of a personal recollection of individuals who've had dengue infection, and it's really the muscle pain and joint pain, severe, debilitating, can't get out of bed pain with high fever that has guided those providers to testing in endemic areas.
Okay, two comments from Dr. Balan. He said, from a personal experience, in answer to Dr. Price's question, that rash is morbilliform and very pruritic. Can you repeat that to the Zoom?
Yeah. Again, here in the Q&A, Dr. Balan is reporting from personal experience, which again, there are a lot of dengue infections in the world. So a lot of people do have experience of them, especially if you have either travel experience or hail from an endemic area. Dr. Balan reports the rash is morbilliform and very pruritic. So thank you for that. Another question here is whether it's possible to have a patient infected with dengue and West Nile virus at the same time. I have not personally read of those cases, but I don't see any reason why you couldn't be. Certainly we have mosquito populations here in Maricopa County that have now shown to be infected with both viruses, so there is the possibility. Yeah.
When I think of like RT-PCR, then I think of it as being relatively expensive in terms of testing still. And you had that slide where you talked about like the thousands of different mosquito captures, like over 4,000 or something, what they did RT-PCR. Like for the county health department, is it relatively cheap because of that volume? Do they have some sort of way of running these that makes it much cheaper than like what we do in the hospital?
Yeah. So the question here is about the cost of PCR testing and the fact that we do so much of it on our mosquito pools and our routine surveillance. So is it cheaper for us? I'm not the person from county to talk to you about the cost of that. I know when we asked environmental services to go back and do that retrospective look at all of the mosquito pools during the summer, cost was a concern because we don't have an unlimited budget. But again, they are doing those on mosquito pools. They're only looking at mosquito pools that have female Aedes mosquitoes in those pools. And moving forward, again, to keep cost in consideration, the prospective testing for dengue in these pools will only be when those pools collect a certain number of female Aedes mosquitoes, and that will trigger those pools to be tested for PCR. In the past, when we've asked environmental services to do mosquito testing, so anytime there's a positive case, we will ask them to do additional testing on pools around that case's home. In the past, we've always done dengue, chikungunya, and Zika testing on those pools. They have asked, since we are specifically looking for dengue now, if they can hold off on doing those additional tests for Zika and chikungunya. So there definitely is a cost consideration into all these testing, but they're because West Nile virus is getting so much attention here in Maricopa County, there's a very robust mosquito surveillance program that's funded.
I have a question for Dr. Balan, if he's still listening, and maybe you could ask it. If we put dengue in our differential, should we test first and get an ID consult later, or should we ask ID to see him first and let ID be the sole decision maker regarding whether the PCR gets sent?
So the question for Dr. Balan or some other ID doc who's on is, if dengue is in your differential, should you test and then talk to ID, or should you consider talking to ID before testing and let ID weigh in on making the decision to test? I'll tell you what my perspective is from public health, and it would be, again, if you have a case where it's on your differential, we would like you to test at this point in time, because again, we're in kind of this case finding period. We're trying to establish endemicity, and so it'd be helpful to do more testing.
You just responded.
Okay. Clinically suspected, refer to the SBAR sent out in November, and testing can be done without an ID consult. Another question came in that I mentioned there being a vaccine. Are there many repeat infections? So certainly in endemic areas, there are repeat infections. So it is believed that an infection by any one of the serogroups will confer lifelong immunity to that serogroup, but there's not cross immunity between the different serogroups. So that is why those subsequent infections do occur and are often more severe than the initial infection. So and again, that's why that the currently licensed vaccine is licensed for individuals who've had a documented first infection it's to prevent infection with, to prevent subsequent infection and more severe disease. So, thank you all for coming and listening. If you would please spread the word. Again, when you start to notice mosquitoes out there, keep yourselves safe from mosquito-borne disease. Protect your skin and make sure that you're talking with patients about it. It's going to become an important thing here in the county. Thanks, Steve.